just wait for that to come up and I'll share my screen. If anyone wants to give me a shout, just in case any tech goes wrong while I'm doing this, please feel free to do so. So welcome everyone to this event working with VCSEs and MNVPs to implement LMNS equity and equality plans. Lots of acronyms there, but we'll talk through them. I'm Celeste, I'm the Maternity Consortium lead and I work in the Sands and Tommy's Joint Policy Unit. It's great to have you all here today. If you're just joining us, please feel free to introduce yourselves in the chat. We've got lots of people signed up working in a range of organisations and in a range of roles, so it would be great to see where everyone is from. Very quickly, if anyone needs captions for this event, they on Teams, they are controlled by individual attendees. So if you'd like to switch those on, if you click more on the top of your menu bar, and then language and speech, and then turn on live captions. I think if it's the first time you're turning them on, you might get another pop-up to sort of set up your settings, but otherwise, as you've set that up, there should be a sort of bar at the bottom with the captions talking through. If that isn't coming up, you might need to leave and rejoin the meeting. Brilliant. So just to give a bit of background for anyone who's not familiar on what the Maternity Consortium is and why we're hosting this event. So the Maternity Consortium is part of something called the VCSE Health and Wellbeing Alliance, which is a partnership between the voluntary sector, the Department of Health and Social Care, NHS England, and the UK Health Security Agency. And in its current iteration, it's a 3-year bit of funding, and each financial year we deliver 3 projects which relate to the aims of reducing health inequalities, facilitating partnership working between voluntary and statutory sectors, and bringing service user voice to policy development and practice improvement. So Tommy's and Sands co-leads the Maternity Consortium, and it's made up of national maternity voices, all of the organisations that make up the Pregnancy and Baby Charities Network, 5 times more the Muslim Women's Network, and LGBT Mummies. And as I said, it's a 3-year bit of funding in its current form. We're in the 3rd year. We've done a range of projects that you might have already been involved in or been to previous events on. But if you haven't, after the event, I'll send over a sort of document which shares all the links to our previous projects and outputs in case you want to have a look at that. But this year we are delivering a project supporting the implementation of local maternity and neonatal systems equity and equality plans, in particular focusing on working in partnership with voluntary community and social enterprise organisations and the Maternity and Neonatal Voices Partnerships to implement those plans. So we've got this sort of project plan up on the slide today. So what we've been doing today is meeting with people across the system to understand how implementation of the equity and equality plans is going, what some of the challenges to implementation are, examples of good practice, and what the Maternity Consortium as a sort of VCSE consortium can support with. And then the second bullet point is what we're doing today. So we're hosting an online event to bring LMNSs, VCSEs, MNVPs and other partners together to sort of reflect on good practice, ask each other questions, share insights, and also to hear a sort of national update from NHS England and where we're at with the equity and equality plans. And hopefully this will be sort of helpful to everyone involved. But if it's not, you can tell us. So once we've done this event, some of the other elements of the project will be to sort of put a call out to gather some of the existing resources out there which might be able to support implementation of equity and equality plans, and then reflecting on sort of what some of the gaps in those resources might be and some of the challenges that were raised in the initial engagement work for the project. We'll develop some short video and written case studies sharing good practice, again to just support implementation of the plans, and we'll put them all in one place in an equity and equality hub and send that out to everyone. So that's what we're doing as part of this project. We've got 2 other projects we're doing this year, which I just mentioned briefly, but I won't go into too much detail. But if anyone does want to talk about these projects in more detail, please feel free to sort of get in touch and we can set up a separate conversation. But the Lullaby Trust, who are Maternity Consortium members, are delivering a project for us around co-producing resources to help healthcare professionals communicate and work with young parents throughout their pregnancy to support safer sleep for babies. And then we're also delivering a project engaging with women and birthing people who have self-harmed, had suicidal thoughts or attempted suicide, and may also have lived experience of domestic abuse, substance use and trauma, to understand their experiences and how services and support can be improved. As I said, please feel free to get in touch with me about those projects, the Equity and Equality Project, or anything we've done in the past. It's great to sort of be connected with lots of different people working in different organisations and different roles, and I'm more than happy to sort of meet to talk through the Maternity Consortium's work in a bit more detail. So on to the agenda for today. We've got a couple of presentations from NHS England, as I said, to give you that update from a national perspective. So we've got Victoria and Fiona doing that for us. We've got a presentation from North East and North Cumbria, LMNS, so Mandy, Steph and Grace. Hopefully if Grace can join us from her previous event, will be talking to us about their work. We'll have a quick 5-minute screen break and then have another presentation from Suffolk and North East Essex LMNS, so Terry and Mollen will talk about their great work. We'll have Q&As dotted throughout, so I'll let you know when the opportunities to ask questions are. Just pop those questions in the chat in Teams, and I will ask them of the speakers once they finish their presentations. And then we'll have a chance to network. So I had originally wrote breakout rooms in the agenda, but I thought I might change it to a chance to network. So before you all start thinking, after that final presentation, I'm going to log off, I really invite you to consider staying for the chance to network. We hear lots of feedback when I'm sort of going out and meeting with people, that people do want the time and space to sort of reflect on their practice and get ideas from other people and sort of talk through any challenges they're facing. So this is an opportunity to do that. I appreciate we're all super busy and there's probably always something else to do, but if you do have that time to join us in the breakout rooms, please do. And then we'll all come back together, have some reflections from the breakout rooms and the event, and then draw the event to a close. So I think that is everything. Let me check my list. I will just say, I think you all have your microphones off, but if you could just keep your microphones off if you're not speaking. And then if the event starts lagging, because there's quite a few of us, turning cameras off. But if you've got it on at the moment, it seems to all be going fine. So yes, I think I'll stop sharing my screen. And then I'm going to hand over to Victoria from NHS England for the first presentation. Thank you, Victoria.
Lovely, thank you, Celeste. And let me share my screen. Okay, hopefully everyone can see that okay. My name is Victoria Morgan. I'm the Programme Manager for Equity and Workforce as part of the Maternity and Neonatal Programme in NHS England. Previously, in terms of my story, I worked in a local system where sadly we had a number of maternal deaths, and I noticed from the newspaper reports that many were from ethnic minority groups, and that really got me interested in health inequalities. And when I joined the national team and the opportunity came up to lead on equity policy work, I was really keen to be involved. I believe that health inequality is a problem for the whole of society, and people from all ethnic backgrounds and social groups need to work together to achieve equity. So that's a bit about me and why I'm involved. In terms of what we will discuss, we'll have a look at the data just to remind you of the picture around health inequalities and race equality, about the work to improve equity, and also where we are going next in terms of measurement and evaluation. When we talk about equity, what that means is that all mothers and babies will achieve health outcomes that are as good as the groups with the best health outcomes. And the other side of that coin is workforce race equality, so that our staff who work in maternity and neonatal care settings their experience does not depend on the colour of their skin, and that our workforce also reflects the local population, including through the management grades. So in terms of the health outcome data, whilst in terms of the national maternity safety ambitions, the interim target of a 20% reduction in stillbirths and neonatal Mortality by 2020 was exceeded. The latest national audit report published 2 months ago found that perinatal mortality rates had sadly increased in the UK in 2021 for the first time in 7 years. And we believe this is a reflection of the direct and indirect impact of the COVID-19 pandemic. What we are seeing in terms of health inequalities is stillbirth and neonatal mortality rates for babies of Black ethnicity, so those are charts on the left of the slide, are increasing at a higher rate than for babies of Asian and white ethnicity. And babies from Black ethnic groups have the highest rates of both stillbirth and neonatal death. When we look at maternal mortality, so that's the chart on the right, Black and Asian mothers and those living in the most deprived areas have between double and quadruple the level of maternal mortality than their comparator groups. Now, I should say that the overall number of maternal deaths are very low, but nevertheless, we really are committed to halve the rate of maternal mortality. And now I'm just going to talk a bit about the workforce race equality side of things. So for staff, data shows that sadly the experience of midwives from ethnic minority groups is worse than that for white midwives, and this is getting worse over time. The NHS People Plan found that where NHS workforce represents the community that it serves, patient care and experience improves. So we've really, in our work to improve equity, really need to think about workforce race equality as well. So what are we doing to tackle health inequalities? Well, first of all, we have 4 fabulous clinical leads. You may know Kate Brintworth, who's our Chief Midwifery Officer, the lead midwife for England. We have Misha Moore, who is an obstetrician, doctor in obstetrics and public health, and Wendy Alayiwola, who is a midwife, and also Naz Khan. And Naz is a health visitor and nurse, and also has practiced in genetic counselling as well. We also have 2 fabulous service user voice representatives as well, Agnes and Rachel. So the work to improve equity and equality is founded on 2 aims and 3 values. Our aims reflect the need to improve health outcomes for mums and babies, and also to improve race equality for staff. And the 3 values that guide the work reflect Sir Michael Marmot's public health framework, so proportionate universalism, so that we have a universal offer but have additional support for those with the highest levels of a disadvantage. And then the values in the NHS Constitution that are particularly important in improving equity and equality. And we'll talk about the social determinants of health and how working collaboratively is particularly important to address that in a minute. So NHS England has worked with parents, with NHS staff, Royal Colleges, the VCSE, arms length bodies and the government to agree what action will be taken. This work is set out in the Equity and Equality Guidance for local maternity and neonatal systems, published 2 years ago now. The guidance asks local maternity and neonatal systems to co-produce equity and equality action plans and publish those as well. And the co-production obviously really important so that clinicians and women and families, the VCSE and the wider community can kind of share their expertise and own the solutions as well to improve equity. And publishing the plan we thought that was really important as well, that each LMNS has published its plan so that the action is clear to everybody and that system partners are accountable for delivery. And there was significant investment to help LMNS to co-produce and publish their plans. So in terms of the asks, there's sort of 4 key asks that the guidance, the equity and equality guidance and then documents, important documents since, have set out. So all LMNS are asked to co-produce the Equity and Equality Action Plan. They have all done that, so that's a tick for that one. And then they were also asked to publish the plan. That needs to happen this year, and 83% have already done so. So we hope the remaining 7 will soon be able to give a big green tick to that as well. And then implementation. So the planning guidance, the NHS planning guidance for this year asks that systems implement their LMNS equity and equality action plans, and the responsibility for assuring implementation is held by ICBs, and so that's in line with the recommendations of NHS England's operating framework. So I'm just going to do a little focus, because we have got a lot of people from the voluntary sector, the VCSE, joining us about what the guidance says about working with the VCSE. So firstly, we know that from Sir Michael Marmot's review that in utero health and the early years affect adult health, and so giving every child the best start in life is the highest priority policy objective. And whilst there is more that the NHS can do to tackle these health inequalities, the social determinants of health are a real driver. The World Health Organization says about 30 to 55% of health outcomes are down to the social determinants of health. So the VCSE, public health, private sector, NHS and government have the role in addressing the social determinants of health, and really recognise that the VCSE is really placed to do things that statutory services can't. And then the second key thing in relation to the VCSE is around an assets approach. Really what this means is that community-centred ways of working work. The asset-based approach sees citizens and communities co-produce health and well-being, and it also empowers communities to help control their futures and create resources for themselves. It's still obviously important to understand the health needs in a community, but it's also about balancing that to look at the assets of the community to restore health as well. And it certainly isn't about the NHS saying to the community, this is all up to you. The NHS really needs to challenge itself as well to provide place-based care. So, for example, we know if you receive care from a midwife or small team of midwives that you know, and those midwives are based in the community, then rates of preterm birth and low birth weight reduce. And staff say that it's also much easier for them to access the assets of the community if they are based within communities, and so they can provide more holistic care. I'm very happy to provide any data about that if people want to read a little bit more. The next thing, I guess, we've talked about the guidance, and the next point really is about the so what factor. So how will we know whether the guidance and the equity and equality action plans that systems produce make a difference? So as well as assuring the action plans, we're also looking at measures. So there are a couple of different types of measures, measures for accountability, some at national level and preterm births at local level, and also measures for quality improvement at local level. So, for example, knowing the proportion of women with complex social factors who attend their booking appointment can help identify a need, and the NHS, for example, might work with partners, including the voluntary sector, to improve access to care. So there's an example in the guidance about how North West London worked with birth companions to understand and respond to the needs of women with complex social factors. We are also evaluating the equity and equality guidance, and that evaluation has been commissioned, and the first year of field work is underway. The aims of the evaluation are to look at the process of implementing the guidance, the impact of the guidance, and also to identify learning as well. So I'm just going to give you some high-level results from the first year of field work. We undertook a survey, had a really good response, particularly from local systems and providers. What we found is that respondents felt confident the 3 values were being implemented well, especially co-production. There weren't any particular surprises in terms of the challenges, in terms of workforce and funding. And local respondents did feel supported by their primary sources of support, their regional teams, maternity clinical network, and their ICSs as well. So that was really encouraging. So we'll have a little bit of a more detailed look at those findings. And first to say, if you responded to the survey, thank you very much. We did get a great response from local providers and service users, and also very broad geographic spread as well. So nearly every local system was responded. We could probably really do with hearing a bit more from the VCSE and local authorities, and in a bit I'll just talk about how you could get involved and still have your say. There's still opportunity to do that. Overall, the guidance was felt to be useful, which was a bit of a relief, to help improve equity for mums and race equality for staff. And what we found was that the more familiar respondents were with the guidance, the more useful they found it as well. In terms of the challenges, workforce and staffing pressures and lack of financial resources were the top two challenges. I think it's fair to say the workforce issues are well known. However, NHS England has given significant funding to LMNS for implementation of the 3-year delivery plan, which includes the equity and equality guidance. So that's something just to explore a bit more. Data was also a challenge for local respondents. Some plans had an excellent analysis of population health and are really using that to drive improvement on the ground. And there's partnership working as well, did come up as an issue for some, but not to as great extent as the other 3. So yeah, we will explore that a bit more in focus groups that will be running in the coming weeks. The support needs very much reflected the challenges in the previous slide. So we did have a national support offer, but quite a lot, about a third of local respondents didn't seem to be feeling that they were getting the support that they needed. So again, we will look at that in the forthcoming fieldwork. And then the other thing, and we asked this a bit early because the survey went out in March, and the planning guidance ask was that implementation began this year. But it was really encouraging to see that quite a large proportion of respondents said they were aware of interventions delivered as a result of the action plans. When we had a look at this by job type, managers and senior managers, about 73% of managers or senior managers were aware of interventions, and that for clinical staff it was about 30%. So we're hoping that when the survey is repeated next year, that awareness of interventions being delivered will grow, because there is more being done on the ground. In terms of the VCSE role in all of this, it's a question you might have. I mean, obviously, the VCSE is very well placed to help with engagement and co-design with underrepresented groups, and giving support with that work. And actually, that could be a way for the VCSE to show what further value added they can offer as well, in a useful way in. And then in terms of next steps, so the evaluation is really helping us to shape the next steps for the strategy and work out what further support might be required for implementation. We've got a series of focus groups underway. We'd really like to see a few more sign-ups from the VCSE and local authorities, and from some NHS services. There is still a small window to sign up. So I'll pop details in the chat. Please be reassured you don't need a huge understanding of the guidance to contribute, because we'll be testing some ideas with people in these groups about support needs and metrics, and collecting good practice examples as well. So thank you for that, and I think I'll hand over for questions.
Thank you, Victoria, for that really helpful overview. If anyone has any questions for Victoria, please post them in the chat, and I'll just start to go through what's already come up. There was actually a question for me, and it was my fault for not saying it at the beginning. The event is being recorded, and the recording and slides will be available afterwards. Please bear with me while we sort of get the slides all together and the recording uploaded. So it will likely be tomorrow or Monday, but that is going to happen. And Danielle has asked Victoria if you're able to share the link to the assets approach guidance you mentioned.
Yes, I am, and I'll pop that in the chat in just a moment.
Amazing. And some of the things that are coming up in the chat, I'll mention, but it might be that it's sort of things that we explore throughout the event, and other people might have ideas, and I can see that's already happening, which is great, because that's the purpose of the event, for people to sort of share ideas and some of the challenges they might be facing in their area. So there is evidence that women and their families who are socially excluded from health inclusion backgrounds, such as Gypsy, Roma, traveller communities and asylum seeker communities, have some of the very poorest health outcomes, including maternity. This data is either not captured at all in Embrace, or poorly captured. What work is being done, if any, to address this? I don't know if Victoria, if you're able to share some thoughts on that.
Yeah, absolutely. So it's a very good point, and I think a really important thing to notice about this guidance is it's not exclusive. The guidance was particularly designed to respond to the national audit report that we have, and we really realised it was important really to keep a focus, that we weren't asking people to do too much and then basically risk not achieving anything. At the moment, there's an issue about being able to record the Gypsy Roma traveller ethnic code, and I won't go into the full technical detail, but it is an NHS-wide issue, and it is something that we're looking to resolve, because we do really recognise that this group are likely to experience significant health inequalities. So yes, we will be able to look at that group in detail later.
Thank you, Victoria. There's another question that some people, again, have already sort of shared some thoughts on in the chat, but if you have anything to add, Victoria, around sort of the workforce element of the guidance. So someone shared, in terms of having a staffing group that represents the local community, our maternity staff do not mirror the diversity of the women in our community. I've done some interviewing for the local uni, and the majority of candidates were white. How can we engage a diverse pool of applicants to our university courses?
Okay, so I think there's a range of things that people can do. For example, I know that some NHS teams actually go and visit schools and particularly target pupils to have experience of maternity care. Other trusts are particularly looking at apprenticeships, are very good at getting local people engaged as well. There is a range of things. I'm very happy if you want to perhaps provide Celeste share an email, and I can ask our the colleagues in the WT&E Directorate, that's Workforce Training and Education Directorate in NHS England, and also Wendy Alay-Wola, who leads on equality, to come back to you on that as well and give you a fuller answer.
Thank you, Victoria.
And that's great to hear. I can see you're targeting local schools directly. I mean, I think it's fair to say it does require effort, but it is so worth it. And that will, in terms of having a local workforce that really reflects the community and the benefits that will bring for patient outcomes, as we've seen from the NHS Workforce Plan.
Thank you, Victoria. And just responding to some of the other things in the chat, Fiona has helpfully reminded me that there is another Health and Wellbeing Alliance project being led by our partners, friends, families and travellers, and the Roma support group. They're doing some work with Gypsy Roma traveller communities on sort of maternity care. So if you haven't seen that, they've published a report recently, so I can include that in the links that go around after the event if people haven't seen that. There's a question in the chat around funding. I wonder if you might be able to speak a bit to that, Victoria, about sort of the future of funding of the equity and equality plans.
Yeah, sorry, I'm struggling to keep up with the chat. Could you just read that one out for me, Celeste?
The question is specifically, is there any further funding expected? But yeah, if you want to speak about it sort of more generally, that's also fine.
Overall, and hopefully I've heard the question correctly, LMNS receive a certain amount of implementation funding to implement all of the deliverables within the 3-year delivery plan for maternity and neonatal services. So that's a plan that sets out everything the maternity and neonatal services to do, and it pulls all the things together, including the equity and equality guidance. So we did make an allowance in there for significant funding for implementation of equity and equality plans, sort of equivalent to those that are familiar with the NHS jargon of an 8A management lead, a full-time 8A management lead. So would really encourage you to bang on your ICS door to make sure that you do get the funding that has been allocated for that. We can't at the moment ring fence funding at all, because that isn't where we're going with the NHS operating framework. That isn't the direction from government or national NHS. So that is so that local systems can have a bit more flexibility in deciding how they want to spend their money. But equity and equality is a really strong theme within the 3-year delivery plan. So absolutely money should be going through to equity and equality. It's one of the 3 key themes, along with personalised care and safety.
Thanks so much, Victoria. I think we'll have to move on in the interest of time. Someone did put a question, can you share an example of when the plan has been implemented well? So hopefully we'll be sharing a couple of those examples at this event, but that is also the aim of the work that Victoria mentioned around the evaluation and also the Maternity Consortium project. So we'll be trying to share lots of examples of good practice that people can hopefully use to draw ideas from in their local area. Please rest assured, if your question hasn't been answered, we will sort of collate them all and think about if there's sort of ways we can answer it through resources, case studies, or even just sort of passing the information on to Victoria and colleagues in NHS England. But thank you so much, Victoria, for kicking us off. I really appreciate the overview. And I'll hand over to Fiona now, also from NHS England.
Thanks, Celeste. My name's Fiona Ellis. I work in the Maternity and Neonatal programme at NHS England, alongside Victoria. And my area of work is choice and personalised care, and that includes service user voice alongside my colleague Lisa Ramsey. So I'm here to kind of add to what Victoria said from a perspective of listening to women and families and really understanding and taking account of what they say as part of equality and equity action plans. And hopefully, I'm mindful of the broad audience today, but hopefully to give you some context that would be useful, whichever perspective you're coming from. I'll get my slides to move. There we go. So just to remind people about the 3-year delivery plan for maternity and neonatal services, that I've put a link to them in the slides, and I can also put that in the chat afterwards if people haven't already had it. I know the slides will be shared afterwards. So the 3-year delivery plan really does help to emphasise the importance of listening to women and families. It's the first of 4 themes outlined in the plan, which the overall aim of the plan is to have safer, more personalised and more equitable maternity and neonatal care. So listening to women and families is top of the list there in the 4 key themes that are included within the plan. Within that theme, there were kind of 3 cogs in that wheel of the things that need to happen to enable the listening to women and families to be really effective. So care that is personalised, working with service users to improve care and improving equity for mothers and babies. So really these all work hand in hand to deliver a really clear co-production approach and making sure that we're using what women and families tell us to improve services and reduce health inequalities. So I could talk about care that is personalised forever because it's my area of expertise, but I'm going to focus on the other 2 cogs of the wheel, specifically for this presentation, given our focus. So looking at improving equity for mothers and babies and working with service users to improve care. So when we're listening to and responding to women and families of all groups, it's really important that we have co-production at all levels. So I've included also a link in here to some documents within NHS England around co-production in case it's something that people aren't familiar with. But actually, this is something that should be the bread and butter of MNVPs, of Maternity and Neonatal Voices Partnerships, in enabling everybody to work together to improve services and reduce health inequalities. In terms of engagement, it's one of the key things that Maternity and Neonatal Voices Partnerships are in place to achieve. And it's really key to make sure that that engagement is appropriate and accessible. So the way that MNVPs coordinate engagement, lead engagement, will be different in terms of the way they approach that in order to make sure that all groups can contribute effectively and meaningfully and want to come forward to contribute. And one of the ways that they will do that is through engagement with voluntary and community sector organisations. So it's really key that both are working in partnership. So VCSEs are involved in the MNVP, and also that the MNVPs are really reaching out to the organisations in their area so that they're not starting from scratch, because as you will all know, the VCSEs will already have links to those groups that we need to hear feedback from. We've already heard in the chat when Victoria was presenting that actually the data we gather doesn't always cover everybody, and the way we're going to make sure that we fill those gaps at the moment, or one of the ways we can do that, is by reaching out to those communities to make sure that we hear what matters to them and can take account of that in reducing our health inequalities and improving our services across maternity and neonatal care. So in terms of the vision for MNVPs, it is to listen and reflect the views of all the local communities to make sure that everybody's heard, including bereaved families and those families who've experienced neonatal care as well. But also, the MNVPs need to have strategic influence and are embedded in decision making. So this isn't just about, people having their say about what happened to them, whilst that is clearly very important. This is about using that to make a strategic difference, to make a difference overall in the way that services are delivered. And also that in order to do that, MNVPs need to have the infrastructure to be successful. This isn't a nice to have, this is a must do in terms of engaging people to inform service improvements. So in terms of how this will happen, this is outlined within the 3-year delivery plan. And just to summarise some of it here, trusts are responsible for involving service users in quality governance and co-production when we're talking about maternity and neonatal services. And ICBs are responsible for commissioning and funding MNVPs. ICBs do have a duty, as well as statutory duty, to engage in public participation. So the MNVPs really are the vehicle for them to do that in terms of maternity and neonatal services. There also is the need now to up our game in relation to how MNVPs are led and structured, and making sure that MNVP leads are remunerated appropriately for the important role that they're now funding in coordinating all that activity in their area. Many of you will know that the MNVP guidance is long awaited. That's yet to be published, but we will get that published as soon as we can. And once that is available, it will provide more advice to ICBs and trusts on what they should be doing to engage and ensure that everybody has their voice heard, and to make sure that there are some examples there of good practice that areas can use to improve the engagement that they're doing and the way in which their MNVP is structured and the infrastructure around that. Thank you. I'm really happy. I'm mindful that my presentation was short and sweet. I'm really happy to take any questions, and also I'll put some links in the chat that are in the presentation too.
Thanks so much, Fiona. Let's see if there are any questions in the chat. If anyone has any, please do post them in there. I think there's a question around what work is being done to engage a more diverse voice in the MNVPs. I don't know if you have a sort of national perspective on that, Fiona.
That is, we'll be encouraging that through the MNVP guidance when that is released, but it's a local responsibility to make sure that each MNVP reflects the diversity of the populations in which they're working, and that'll be different for each MNVP depending on obviously the area in which they're operating, and it will be different how they do that. So it might be that for some areas there is more working with VCSEs. It might be that for others they actually recruit a team of people within the MNVP who aim to reflect that diversity. But it's the responsibility of the ICBs and the LMNSs and MNVPs to get that in place that reflects their own local demographic.
Thanks so much, Fiona. There's a few comments in the chat generally about some of the challenges being faced in terms of funding and capacity of engaging VCSEs and MNVPs. And yeah, please rest assured we do hear that and are sort of passing it on, and as sort of the Maternity Consortium thinking about ways we can sort of try and support with that through our work, and hopefully some of the examples we have today and some of the examples we will be sharing through our video case studies, we'll look at that as well. There's a question, what is ICB? ICB is Integrated Care Board.
Sorry. Sorry for not clarifying that. Can I just pick up on Verity's point in the chat around Donna Ockenden picking up that MNVPs don't represent local populations? Recent survey that National Maternity Voices have undertaken actually showed that whilst they don't reflect still the diversity of voices across the organisations, actually we're better in terms of the MNVP chairs and leads actually being a more diverse mix of people. The difficulty we have in that is it's really helpful to understand how that works within each area. So we can look at kind of national demographics and what nationally the MNVP demographics are like in terms of who's leading that, but actually for each area that will be different in terms of what makeup of MNVPs will mean it's representing the demographic, but the diversity within MNVPs is improving, which is positive.
Thanks, Fiona. Victoria, were you coming off mute because you wanted to add something? I just wanted to check.
Yeah, I was actually, Fiona's just taking the words out of my mouth, so that's absolutely fine. Yeah, there was some real support that was in place for a few years, which really encouraged diversity, and just as Fiona said, of our MNVPs. And as Fiona said, we can really see a difference. It's really encouraging, but still more to do, but made some very good progress recently.
Thank you. And there's a question for me, if the Maternity Consortium has a directory for local services to help MNVPs link to local VCSA organisations. Unfortunately, we don't, and I have received this request quite a lot. Unfortunately, with the sort of way that the Health and Wellbeing Alliance projects run, it's not necessarily something we're able to do with the funding and the grant that we're working on, but we are trying to think of ways to support that. So we have partners in the Health and Wellbeing Alliance who might be able to support in terms of giving tips and ideas for LMNSs and MVPs to sort of link in with different parts of the system. So sort of working with faith leaders and community influencers and different roles in different parts of the system. So if there are any sort of community connector roles in local authorities. So we are thinking about if there's sort of resources we can develop to support you to take that forward within your local area. But unfortunately, at the moment, we're not able to develop a sort of directory with all of the VCSEs across the country. And there is something around, I don't know, Victoria, Fiona, around the asset mapping that should be taking place, I guess.
Yeah, absolutely. It's a really good point, Celeste. So one of the things that the Equity and Equality Guidance asked local maternity and neonatal systems to do in the planning phase, as well as plan how they're going to do their co-production, kind of bring together an asset map, which doesn't mean it has to be a map form, but it's more about identifying those sort of community assets that would be particularly helpful to maternity services to address the social determinants of health. What we really find is, in fact, when the NHS provides place-based care, when that's appropriate, obviously it's not always appropriate, it's very important to have specialist care as well, for example, in our neonatal units, but when the NHS it's appropriate to provide place-based care, that connection with the community assets happens much more easily. Staff find that much easier to do when they're based in the community and they know their local communities and what is available to mothers and families and babies.
Thank you, Victoria. And yes, the Hearts and Minds Partnership do have a map of local VCSEs working on perinatal mental health, so do check that link out in the chat as well. And thank you all for your comments and questions in the chat. We will have to move on again, just in the interest of time, but I'm just looking through and they're all really helpful and things that we will sort of consider and take forward to see if we can develop some of the resources in response to some of these challenges that are being raised in the chat. So really appreciate you sharing. And thanks so much, Victoria and Fiona, for sort of setting the scene for us from a national perspective. Really appreciate it. So I'm going to hand over now to Mandy, Steph and Grace, if she's managed to make it from her previous event, for the next presentation. Thank you. Oh, and sorry, if you have any questions for Mandy, Steph and Grace, please post them in the chat throughout the presentation.
Thank you so much. I'll just start to share my presentation. Can everybody see that? Great. Okay, and thank you everybody for the opportunity of presenting today. My name's Mandy Tester. I'm a programme lead and I work for the North East North Cumbria LMNS, and I'm joined by Steph and Grace, and throughout the presentation Steph and Grace will introduce themselves. So initially, actually, when we heard of the opportunity to present at the event, we thought, are we actually too early, almost on our journey? But we're actually taking today as an opportunity to to learn from others, receive feedback from ourselves for our work that we're doing, and look also for for best practice. Just a little bit of background about the North East and North Cumbria. So the area is quite large. It covers the cities, industrial areas. We have open countryside, and it's the particularly coastal and the towns and villages. The challenges, that for health and care services is that it's quite different depending on the location. So in addition, we have that mix of people who live in different places. So that's even when comparing a whole local authority area, and that varies greatly. So some populations are older, others are younger, some more affluent, and some have larger populations from the ethnic minority groups, and others are less diverse in that area. So our Equity and Equality Action Plan has been published. It does focus on equity for the mothers, babies from Black, Asian and mixed ethnic groups and those living in deprivation. And as we throughout the threads, it does demonstrate that the evidence that women and babies from Black, Asian and mixed ethnic groups and those living in deprivation do have the poorer, worst outcomes than the rest of the population. Our action plan also focuses on staff from the Black, Asian, mixed ethnic groups. The first slide that I'd like to show you has been co-produced with our service users and details how, as an LMS, we involve our service users in our work. So we've seen throughout the presentations around the keys of the 3-year delivery plan for maternity and neonatal services, and that is about listening to and working with women and families with compassion. The document also details that voices of all women, including those from diverse backgrounds, must be heard, and services should work together closely with all service users to collaboratively plan, design and deliver and improve care. As an LMNS, we always aim to work as one team with service users, so that we're ensuring that the voices of women and birthing people and their families and carers are included in everything that we actually do. As you can see from the slide that's been presented, we do have three types of service users who we work alongside. The service user voice representatives, they sit on there's 3, and they sit on the LMNS board, and they work at a strategic level and offer advice and guidance, and as well as facilitating our support in our network of MNVPs. The role is also to challenge and place the voice of the service user at the forefront of decision making for maternity and the neonatal system. The 10 MNVPs that sit across the 8 trusts in the North East North Cumbria, and they work actually in partnership to connect everyone involved in the provision of maternity and neonatal care they really are a place where women's voices are where they're actually represented. And they work at a local level alongside the trust to provide the right services, provide feedback and ensure the voices of women are heard. We also have another group, and that's the third one you can see on the slide, the Patient and Public Voice Partners, and they're included in a range of subgroups, for example, the Workforce Steering Group, and the role is to champion the views of women, babies and families throughout the design and delivery of maternity and neonatal services. So I'm just going to show you now is the following slides will do a transition. It details how we listen, how we're responding to service users. The first slide details at Community Place, the MVP engagement events, so those listening events, whether they're the 15 steps, the MVP, the meetings as well. What we transition to next is about how the MVPs sit with the trust as well. So the MVPs have co-produced annual work plans. They have annual budgets, and we've been able to support the MVPs having laptops. And the MVP leads sit at the trust governance and quality safety meetings where service user experience and complaint themes are shared and lessons learned. The next transition details how those voices are fed into the LMNS subgroups, for example, the Maternity Engagement Group, which is actually co-chaired by our 3 service users, and details how discussions and escalations and feedback from the LMNS board, and it's giving that two-way feedback. And finally, the transition is demonstrating how that feedback loop is closed across the whole of the system, covering whether it's community, local trust, and then at ICB level, and how the service users are embedded in the structure. At the moment, these slides are in draft, so appreciate that they are quite busy, but we wanted to demonstrate how we're trying to ensure that voice is heard throughout our system approach. What I'd like to do now is hand over to Steph, who is South Tees MNVP lead. Thank you, Steph.
Thank you. Hello, nice to meet you all. I'm just going to really explain a little bit about how I came to be in this role and how I came to be engaged within the Equity and Equality Plan, just to give people an idea of working alongside the MNVP from that point of view. So kind of what brought me here was when I was applying for the role to be the MNVP lead, was the first time I came across this idea of inequality, just based solely on race alone, which just shows my privilege and my naivety, really. But a bit like what you referred to, Victoria, right at the beginning, when I started to look at the information and see what was there, I was honestly shocked and horrified that was something that was still so prevalent in this day and age. And so from that point, I kind of put a lot of time and energy into seeing what we can do within this role to help try to rectify that and to help address that issue. So within our MVP, we do have bi-monthly meetings that are attended by about 15 to 20 people of clinicians and service users and service user reps. But alongside that, we also have a subgroup, an ethnic diversity subgroup, that's chaired by Dr. Susan Jones, who was a former researcher at the local university, Teesside University. So that subgroup was set up initially just with 3 people who, much like I did, before that time acknowledged that we weren't really hearing the voices. Some of the comments I'm seeing coming up in the chat were, how are we truly hearing the voices of different people? And they acknowledged that wasn't happening within the South Tees MNVP, and so set up a subgroup whose role was to fully engage with people from different ethnic diverse backgrounds and cultures. And they set up initially with just kind of 3 people and an idea that something needed to be tackled. And now that's a monthly subgroup of sort of 10 attendees at the meeting, but an active email list of probably like 30 to 40 people engaging, primarily volunteer groups and people working within the areas that within the local communities, I should say. So they do absolutely phenomenal work, and obviously being the lead of the actual MNVP allows me to also be part of that subgroup and see the work that they're doing. They engage with a variety of different people and different groups, local organisations such as Nerve Fitness, which is an organisation that helps South Asian women through health and fitness. Ubuntu, which is an organisation that works with families from the African continent, and when they've come over to the country and they're trying to negotiate discussions with local councils and the fear that can come alongside that. So we work really closely with that organisation as well. And that's just an example of a couple of organisations. We've recently gone to do some listening events in the local mosque to hear about their birthing experiences. And so that work's all coming through the subgroup that's part of the MNVP. Alongside that, we've done a big research project into developing how we can develop better pathways to hear these voices. And the idea was then that we would, once that project's finished, we will be able to, there'll be kind of a framework then that might be able to be adapted by other MNVPs if that's helpful. And we've also done things, there's been some points about recruitment. We've worked with the midwives that were already training at Teesside University that were from a different ethnic background, and created promotional videos that have been shared on the LMNS website and things as well. So trying different ideas to help make sure that we are hearing the voices of all the women in the area. We also attend the Freshers Week and the local health week at the university, and they've been really successful in speaking to women that have come over pregnant, maybe with their partner who's doing a course at the university. So that's a little bit about the group, and I think really that then doing that work and then speaking with the LMNS through our MEG is what led me to be part of the Equity and Equality Planning Group. So I'm very much involved as a service user voice in the work that went into creating the regional, the LMNS Equity and Equality Plan. Within our LMNS, a lot of all of the MVP leads and co-leads work really closely together. So we do, like Mandy said, attend the MEG meeting. That's every month, and we're part of a WhatsApp group. So having one service, like one lead involved in something like the Equity and Equality Plan, gives access to all of those voices as well, because we're very much into sharing, chatting together, asking each other's advice, and then going into the communities across the region to get feedback on that. So that's been really useful. So then off the back of the Equity and Equality Plan, one thing that we were absolutely adamant, we didn't want the plan to just become something that we've done and then we can tick and say, well done, we've done that, we're asked to do it, we've done it now, let's put it on the shelf. It's very much want it to be a living document and something that we're using to actually influence what is happening in the area and in the region. And so this steering group was formed, and as part of the steering group, we're taking all the actions. Part of our is a 162-page document, is it, our Equity and Equality Plan. We did also produce a plan on the page to mean that it was just one page. So yeah, we're going through all the actions as part of the steering group, making sure that the actions in that plan are continually being done and referred to, and it's not just sitting there on a shelf not doing anything. So that's just a very garbled reason of who I am, and just me. When I say I mean I am representative of the service user voice, is what I'm trying to say. And then Mandy's going to talk a little bit more about like strategically how things were put into place.
Thanks so much, Steph. Thank you. So as Steph mentioned, we've now established that Equity and Equality Steering Group, and that the purpose of the group is to support the enable of the Equity and Equality Action Plan. Steph is the co-lead alongside Hamid, who is the ICB Director for Equity and Inclusion. So we have the terms of reference that have been agreed, and that steering group will oversee the development of the plan and any subsequent projects by monitoring those key actions. What we have seen is that much of our work, actually, the first year has been to ensure we have the right infrastructure in place, and that's almost to ensure how we support and monitor and challenge how well we address inequity and equality. And it does provide us with that opportunity to reflect on our own progress and look forward to how we can improve the care for women, birthing people and babies and their families. As a region and a local maternity and neonatal system and an ICB board, we see that it's about us working together with our partners across the system to get the best at getting better at as improving outcomes. We know that we do. I think we do have a challenge around ensuring that we're continuing to be representative of our populations that we serve. So we have a scoping exercise underway to identify additional members to our steering group and ensure we get the representation from the Black, Asian and mixed ethnic group, and continue to engage with the voluntary sector. So there really is so much good practice that evident that's taken place across the North East and North Cumbria, and our commitment is about working with our partners at a system level to be the best at getting better, improving those health outcomes. And what I'd like to share today is a couple of projects that have been established, which is actually supporting the wider system working, and they've been in response to the Equity and Equality steering group. So a task and finish group has actually been set up and to develop a regional pathway which standardises care for vulnerable migrant women. So within the 3-year delivery plan, it does actually detail some specific actions about the need to address the vulnerable groups, such as those seeking asylum and refugees. And it has been identified that there isn't actually a North East North Cumbria specific care pathway for migrant women. Therefore, the vulnerable migrant pathway scoping exercise has taken place to identify best practice across all of our 8 trusts in the North East North Cumbria, which will help to develop that that regional practice. We are aware of so much good practice that actually is taking place about supporting via the specialist midwives, caring for those migrant women that are staying at the hotels and ensuring that there is continuity and consistency. So there is longer appointment times, 45 minutes at the 2 weekly intervals. And we have welfare support officers who act as a liaison, and they arrange, for example, taxis to support women getting to appointments outside of the hotel. There's been connections with the Bangladeshi Centre, and we can already see this is having an impact on reducing work for other work streams and other caseloads, and having an impact with very late bookings. So we really are aware that there is some good practice, but it's how we can bring that good practice and have actually a regional pathway. So the group is being led by the public health midwives, and it is in its early infancy, but there is a real commitment to ensuring that we develop this regional pathway. And how we're able to do that is break out into different work stream groups. So I won't go through them, individually, but probably what I can say is that something about the directory of VCSE resources, that's something that we are picking up in the directory of resources, the second from last bullet point, because we are recognising that we do need to engage and increase the VCSE representation. So we met yesterday, which was our second meeting in the task and finish group, and we did break into those smaller elements. And what we have an end date of March 2024 for a completion of this regional pathway. Another project that is being part of the North East North Cumbria Equity and Equality is supporting digital inclusion in maternity. So I am going to hand over to Grace to introduce herself, and thank you. Thanks, Grace.
Hello, everybody. My name's Grace. I'm the digital midwife across South Tees, and I'm also the lead digital midwife for equity and inclusion in the LMNS. So for those of you that don't know what a digital midwife is, because it's a bit of a bizarre title, I basically lead the digital agenda for all of maternity services and look at how we can make improvements to our safety and care using digital solutions. And when I first started doing this role, I could see loads and loads of really huge benefits to patient safety for the clinical staff, which obviously has an impact on the women. And I was so desperate to move things forward and get rid of the outdated paper notes and harness digital technology that I really had to look at what barriers we were going to face and what was going to make it not work in order to overcome them and make sure that if I was going to do it, I was going to do it right and I was going to do it once. And one of the biggest barriers that I really struggled with was digital inclusion. So I think that we assume that as a group of our generation, we would feel like we'd lost our right arm if we left the house without our mobile phone. And it was definitely in that generation where we're constantly using our phones for banking, shopping. It always seems to be in my right hand or very close to me on a desk somewhere. But we have got quite a large group of women who don't have access to the internet, who don't have the latest iPhones, who were very quickly going to fall behind and not have the same access to their maternity records as others. And I think the further that we got on with digital technology, that divide was going to become bigger and bigger. So that was me really identifying the issue, and I couldn't really get away from the fact that the midwives were saying to me, well, what about the women who don't have a phone? What about women who don't have internet? And I looked at what our data said, and using our old system, our data collection wasn't as good, but it was showing that up to 17% of our women that we were booking each month were from the most deprived backgrounds. And I've since repeated that looking at that data since we've implemented Badgernet, and it's actually much higher. It's actually almost up to 38% of our women are from the most deprived areas that we book across Middlesbrough. So that highlights that there is a real issue that we needed to do something about. So I began to look for what available resources there was, and I wasn't coming up with very much. There wasn't really anything in our area that the government offered, or there was no grants that these women could apply for to give them access to a phone or to data. Which is when I come across a lovely little charity in Middlesbrough called the Hope Foundation. They've got a device library, so you can go and rent a laptop, a tablet, a phone, just the same way as you can a book. And I thought that was really amazing. But what they'd also set up, because they identified the same issue in COVID, particularly with children who were trying to do online learning and weren't able to get onto the internet, they set up a website called Verbed IT, and what that is it's that you can become a drop-off and distributor of devices. They pick up the devices that have been donated, they wipe them all back to factory settings, and then if you're a distributing site, you can then distribute them to whoever you feel needs them. They also pointed me in the direction of another company called the Good Things Foundation, and I was able to apply for a grant to be able to hand out SIM cards with 6 months of data on, which you can give a maximum of 12 months of data, which was perfect for that that 9 months of pregnancy, if you like. But it also meant that when the pregnancy ended, that they still had enough data to be able to ring the GP if they've got any concerns about the baby. They were able to access information online. They were able to get access to support groups that really meet the individual needs of their baby, rather than just waiting for that information to come from the healthcare professional. So in my head, I thought, well, this is great. We've got the devices, we've got the SIM cards. I can hand them out. That's going to make a real difference. There's definitely another pillar of work that we need to do some work on, and I'm hoping that in the next kind of 12 months that we get that funding and I'm able to offer digital skills support, because although they've got the phone, they've got the SIM card, we're looking at a group of people who might not know how to set up an email address, and they might not know how to actually have the digital skills to be able to use the apps that we're giving them. So that's something that we're looking for in the future. But for now, I'd set up this plan. How am I going to help them? I'm going to give them a phone, I'm going to give them data, and the midwives are going to support them to be able to access the app. And the midwives agreed to do that so that nobody was getting left behind. So we got that signed off by the trust, which was amazing. And we launched it in June, and I think that since June I've given 12 women phones and SIM cards and been able to make sure that they've got the same access to their maternity records as everybody else in the patch. And that's really without advertising it, because I didn't want to advertise it too soon until I knew that it worked. And it does work, and it's brilliant. So there's going to be lots of promotion, and we're hoping to spread that work across the LMNS. The LMNS have been really, really supportive. They're supporting some like deep discovery. It's not research, it's like a discovery piece of work where we can really hone in on our South Tees women and find out what is the barriers to them accessing digital information. Is it that they don't have the device, or is it that they're prioritising other things? What are they using the internet for? What can we do to make it better? And I want to keep it quite open-ended so that then women can tell us exactly what we need to do to make it better for them. So that's kind of the next thing that we're going to be doing. And off the back of that, we decided to set up a digital inclusion workshop, which is going to be on the 5th of December in Durham. Thanks, Mandy, for advertising that. It's going to be on the 5th of December in Durham. And what we're hoping to do is to really set the scene and make people understand how pivotal this is to the success of the maternity services as we move into the, you know, we're working in the 21st century now, and we're using technology for everything. And yes, it is going to improve safety, but only if we bring everybody along with us. So we want to get people interested in it. I also don't want to just be doing this on my own. So I want to get as many people involved and say, right, this is the scenario. What would you do? Where would you signpost it to? What ideas have you got? And then get them to hone in on one point, and everyone takes some actions from that, so that it's not just us at South Tees that are doing it. It's everybody's going to get involved in really making sure that digital inclusion is high on the priorities. And yeah, in turn, that's going to inform our digital inclusion roadmap and plan. And hopefully this time next year, we might be able to say that every woman in the region's got the exact same opportunities to access the records in the same way. I think that's it. If anybody has any questions, I'm happy to answer any, or feel free to email me if you want me to share any resources or anything about how we've done what we've done. Thank you.
Thanks, Grace. Steph, do you want me to cover this slide?
Oh, sorry guys, I didn't realise that's on mute. Yeah, just to summarise, I was just saying it's hard to follow Grace because she's so passionate about what she talks about. You end up listening and then like, oh wait, I meant to speak. We were, like Mandy said at the beginning, we were a bit reluctant to say yes to this because we feared that when you agree to present at something that makes you look that you think like you know what you're doing. And part of the reason that changed my mind, our mind, was that really we thought maybe it was an opportunity that if we present what we are doing, it allows us to be open to people to comment on, give us suggestions back and feedback on things, and they might have ideas that we could do differently. So just to say, we are only like a year in. We've only had 2-3 meetings of our equity equality steering group. We are really aware that we haven't got a huge representation for the voluntary sector yet, but it's an ongoing action that every month we're trying to recruit more and more people. Obviously we're able to use links through, say, the subgroup at South Tees, and the hope is that they will then like speak to counterparts when they go to conferences together. They can speak to their counterparts and say, have you heard about this steering group? You maybe should look to joining it. So we're very much at the beginning of our journey, and it's all just about making sure that we implement the actions that are there in the plan. Obviously the things are listed on the slide there, and examples of us listening and working with families and continuing to work with VCSE and the MVP. Hopefully we've kind of covered within this presentation. But yeah, we're not experts. We're just at the beginning of our little journey, and but we've got a lot of people involved that are really passionate about making sure that there is going to be equality across the region, that it will be one of the safest place to be pregnant. So yeah, and if you do have any questions, please ask. There's a bit of a question on interpretation and translation, and that is something that has come to the steering group, that we've just noticed it's a theme across the region, that it's a barrier, and it's something that where everybody's struggling with. So that has come to the steering group, and that is on the agenda to look at ways that we can tackle that. So again, if anyone's doing a really good job of that, let us know, and then we're looking to implement things across the region.
I can add to that as well, Steph. So when we always know that women that don't speak English is a barrier to being able to provide care. And I know that Badgernet themselves are doing a lot of work on how can they translate them notes, because obviously people write clinical notes in shorthand and it doesn't always translate into languages, and there's lots and lots of languages that people speak. They have initially made the landing page of Badgernet accessible in the top 9 languages across the UK, which is a start, and I know that there's still a lot of work to do, and they're very, very aware of that. What we've done at South Tees is that we've made as many of our leaflets accessible in as many different languages as we can, so that the midwife can, you know, if she's got a lady that speaks Somalian, she can push that leaflet out to her in Somalian so she can read it. The other thing, the feedback that we've got from the women is that on the paper notes, they just actually couldn't read them. Whereas at least with the Badgernet notes, that they can copy and paste them into a translator, so that they actually prefer doing it in Badgernet than on paper. So although it is still a barrier and there's definitely a lot of work to be done, I think that it's still a step forward for them women, because before they wouldn't have been able to read anything, and now at least we can give them some information in their language. So it's not all bad.
Great. Thank you so much, Mandy, Steph and Grace, for your presentation. It's really helpful to see how you sort of included VCSEs and MNVPs and other elements of service user voice, both sort of in the development and ongoing implementation of the plans, but also in specific projects. And thank you for answering some of the questions that came up in the chat already. If anyone does have any more questions, please post them in the chat. Steph, you've already answered in the chat, but just for the purpose of people watching back on the recording, there was a question around including neonatal voice, and I wonder if you might want to speak a bit more to that on the recording.
Absolutely. Yes. Sorry, Steph.
No, go for it.
We'll do a dual act. We are recognising as an LMNS about having the neonatal voice, and as part of the service user voice representative work plans, there's a particular action within there to ensure that we have that neonatal voice being heard. So I think there is some steps being taken as well. So Steph, I probably wanted from a local MVP as well.
Yeah, so there was a call for MVPs to become MNVPs about a year ago, and we made the decision to do that immediately, even if it was only a name rather than action initially. Just that thing of like stepping out and making us do it. And so then we've written it into our work plan for this year that we want to engage a neonatal voice. I'd love to have the funding to be able to offer like half a day for a neonatal rep, but we just don't have that. So instead I've been in touch with the neonatal ward, and I'm working with the outreach sister who's put me in touch with the family hubs and the organisations and the groups that they're doing there. And so kind of pledging just of my own time to try and go to a group once a month, just to make sure that we are getting the voices of the neonatals, because the meetings that we have, although we do our best to try and make them accessible for service users, they do have to also have a formal kind of meeting element. And in theory, a neonatal parent, because we're meeting in the hospital, can just come down the stairs, but who's going to want to leave the bedside of the child for a meeting? Nobody wants to do that. So we're just trying to find other ways of getting the voices to the table, and some going along to some of the meetings that the family hubs are doing is one way of doing it at the moment.
Thanks so much. And there's another question around including perinatal mental health team voice.
Yes, I was just going to reply to, I think it was Katie. I think I was just going to reply to. Yes, we do. We have our LMNS subgroups, but we also have our clinical networks groups, and we have service user voice representation embedded throughout those working groups.
Thank you. And there's lots of nice comments in the chat. Thanking you for your presentation, and there were lots of applause reactions if anyone sharing the slides didn't see that, so do have a look at those. Also lots of people sort of sharing examples of things they're doing and working in a similar space in their area, so that's really great to see in the chat. Please continue doing that. Just to pick up on one of the points in the presentation that is really important around the reason you were perhaps initially a bit apprehensive about doing this presentation but then decided to do it. I hear that a lot. So as I said, we did the engagement work across the country to understand how implementation was going, and I hear that a lot from people around addressing sort of health inequalities is a really big task, and it can be challenging and overwhelming, and that's why we're here, and that's why we're sort of putting on these events and giving people the sort of time and space to reflect and share good practice, but also to just learn from each other, and it is sometimes that we're not going to get it right straight away, and we have to just keep working at it and go back and think again, and sometimes we can get ideas that we can adapt for our different areas. So really appreciate you coming along to present. Karen, did you have a question for this presentation?
Yeah, just I was actually typing the chat then, and just to come back to, sorry, I don't know your name, it's lead for South Tees. Is it
me, sorry, Steph. Yeah.
Sorry, I think we met at the Better Birth conference. You just mentioned about the neonatal voices, and I totally agree. And those MNVPs that do have a dedicated neonatal person, they often run their own neonatal specific engagement events or meetings. And I know if Kelly Fazackley's on the call, Kelly Fazackley does that. I know Victoria Walsh did over in Liverpool, and I would encourage, if you have got someone that you do that is really helpful. In lieu of that, at the moment, I don't think you've got a me. I'm a parent and family engagement lead for the network. I don't think you've got a me in your area, but you will have care coordinators, and I would encourage you to speak to them and their PAG, their parent advisory group for neonatal, because that could be a way. And that joint working between the two is really, really crucial. We're doing a lot of that in Yorkshire and Humber. It's working well.
The care coordinators attend all of our MVP meetings. They send a rep to every MVP meeting. They are really supportive. But yeah, absolutely. We've tried to look at creative ways of, maybe just going and offering coffee in the family room, the neonatal unit and things like that. But as always, it just comes down to time allowance. Yeah. I only do 2 days a month. So it's just, just time allowance. But we're trying to think of slightly more creative ways that maybe other people within our MVP wider group might go up and do that sort of thing as well. But yeah, thank you, Karen. Thank you.
No worries.
Thank you. And there's a question around if Badgernet is something that VCSEs can let families know about during their personalised support journey. If you guys have any thoughts on that.
Do you mean that VCSEs can share information on Badgernet, or that Badgernet can share information on VCSEs?
Abby, I don't know if you want to come in.
I've seen that in the chat, and I was just trying to figure out which way around the question was.
Yeah, thanks for bringing that up, Chair Stay. It was just to ask. I've never heard of it, and I've been a peer support worker for about 5 years, and God, that would have been really good to know about, to tell specific mums and families about. I just wondered if that's something that we can, if it's appropriate, that we can.
So Badgernet, what Badgernet is, it's an electronic patient record which has replaced the paper notes. So I'm sure if you've supported families for over 5 years, you'll remember the notorious paper notes that women carry around with them. Now in our region, we've only got one trust in our whole region that's not using Badgernet as their maternity record, which is Sunderland, and Sunderland are due to transfer onto Badgernet in the new year. So that might be why you've not really had much experience with it, because we only went live in April this year. Absolutely, with the link to our Badgernet self-referral form is on our South Tees website. If you type into Google self-refer to South Tees maternity, you'll be able to see that there's an online referral form. And you can inform the women that that's ideally how they should book. Obviously, if they don't have access to a device or to the internet at that point, they can still call up and book the old-fashioned way, and then I would support them with getting access from that point. There's quite a lot of information about Badgernet on our website, and then once the women are set up on Badgernet and they've got access to the app, they've then got access to all of the leaflets that we've put onto there, and the midwives can decide to push leaflets out to them at set points in their pregnancy as like a recommended reading. So if they've had, if they're on a specific pathway and they want to send them a leaflet out, they can do it that way. So it's a really good way of sharing information, but they would only get access to the app once they've booked once they've kind of referred into maternity services.
Do you have any idea if that's being adapted nationally, or is it more kind of in the northeast?
So I think that Badgernet cover 1/3 of maternity services in England. They cover all of the maternity services in Scotland, and I think it's just ever growing. So there's a couple of different trailblazing maternity systems, which is Badgernet and K2, so they're the most popular ones. And then there's some others like Euroking, Medway, things like that. And I'm not sure the kind of specification on all of them, because I've lived and breathed and sleep Badgernet for such a long time now that I couldn't quite remember for our options appraisal. But I'm sure that K2 and Badgernet are very, very similar in terms of they've both got the patient app to share information with women. And the others will probably not be far behind, because there's kind of a national specification on what them electronic patient records for maternity services should look like now.
Okay. Thanks so much, Grace.
Thank you, Victoria. Did you want to come in on that?
No, Grace is far more knowledgeable than I on that subject.
Brilliant. All right. Well, thank you again, Mandy, Steph, and Grace, for your amazing presentation. Really, really appreciate it. We're now just going to take a short screen break before the next presentation. So I'm going to be very specific with this because we are running slightly over. If people could come back at 33 minutes past, so we've got 5-minute screen break. If needed, feel free to turn your cameras off, and then I'll pop back up at 33 past. Welcome back, everyone. Hope you had a chance to get a drink and that you weren't sitting there responding to emails. Great. I just see, please feel free to go back on camera if you would like to, but no pressure if you don't. I am now very pleased to hand over to Terry and Molyn for their presentation.
Thank you, Celeste. Hello, everybody. My name's Terry Gavin-Jones. I am the Senior Clinical Lead for Maternity across Suffolk and North East Essex LMNS, our local maternity and neonatal system. My pronouns are she, her. It's really nice to be with you today. I am co-presenting with Molyn today, and I'm going to ask her to introduce herself.
Thank you. Can you hear me?
Yes.
Yeah, thank you. My name is Molyn Delve. I'm based in Ipswich. I'm founder and CEO of Phoebe. We're women's charity, specialist women's charity. We specialize in supporting domestic women, migrant women, Black and minoritized migrant women fleeing domestic abuse. And so what's very important for us for this meeting that we've been invited to is that we...
Hello, sorry, I know we're multitasking.
Sorry, we're a frontline and grassroots based organization, and we're user led, and therefore our women are part and parcel of all the work that we do. So that's the key for us to sort of hang on to, and we're very much solution focused because they bring a lot of problems, multiple barriers, and so we're intersectional approaches that we use because our women bring with them very much a lot of multiple challenges. Yeah, thank you.
Thank you, Molyn. I'm going to share my slides with you all, so I'll just get up the presentation for you and put it onto slideshow. Okay, so hoping that that's come up. I'm pretty sure it must have done. Shout if it doesn't. Okay, so I am going to take you on a whistle-stop tour pretty quickly around how we did some of the stuff that we did and how we started. And I think you're probably all really familiar with the 2021 equity and equality analysis, which was our first starting really. We absolutely used public health and fingertips for some of that data. And I think it's fair to say that working in maternity, when you're faced and tasked with an analysis document, it felt pretty overwhelming. So I have to say there were lots and lots of people involved in all of this. That's some of the data that Fingertips pulled out for us. And then within that first scoping document, of course, we started to do some asset mapping. It really made up part of the who we wanted to be involved. So that was really me and public health looking at who was out there. Some of the organisations that were out there in the third sector, as a midwife, I'd never heard of them before. And a lot of the time it was as simple as Googling what's in my area, actually. And I think when we start to talk about community asset mapping, it sounds really, really complicated. But you know what? It was me and a phone and Google. So, and then calling them, emailing them, going, do you want to work with maternity? Come and join us. That'd be great. So asset mapping was really essential. That's just a bit of a screenshot. And then really get into the nuts and bolts, because after we'd done the asset mapping, after we understood who was out there already, as an LMNS, and you know, it's really important to say that an LMNS is everybody. So it's not a standalone organisation. That includes the maternity hospitals that we are partnered with, which is obviously Ipswich and Colchester as ESNEFT and West Suffolk, but the LMNS is also the VCSE sector as well. It's also health visiting, it's also public health, it's county councils. So as an LMNS, because we are a collaborative, we got together and we took the equity funding in 21-22 and we decided to invest it. And we invested it in VCSE organisations. And to invest it, we had to go out to a tender process. So we went out to tender and we said, if we gave you some money and it wasn't a lot of money, but it was 50k for each organisation. Could you partner with us in maternity? And we put no real restrictions on how that partnership should look like, apart from it should reduce health inequality and it should benefit the community. And out of that, there were 6 organisations. And you can see them here, and Molin with Phoebe is the one representing today, but we also have Ipswich Community Media. We have Petals, which is a baby loss counselling service. We have African Families in the UK. We have Survivors in Transition, who work specifically with survivors of childhood sexual, our young families. So my top tip, and I think today is really about, you know, and again, I think the previous presenter said we're not experts. I'm certainly not an expert, and neither is us as our LMNS, but you can only do what you can and learn from what others have done. So my top tips is absolutely scope your community, even if that is with Google, and then approach the community, and then be consistent in that approach, and then be prepared for some resistance. Actually, was my lesson around this. I kind of thought it would be easy. I thought, because I was full of enthusiasm, I'd go and I'd say, come on work with us. But actually there was resistance, and there was a lot of reason for that resistance. And I'm going to ask Molin the question now. So before the LMNS partnership with maternity, how was your relationship with maternity? Do you want to talk a bit about that, Molin?
Yes, thank you, Terry. Our relationship was non-existent. We felt, you know, that the NHS maternity was sort of quite sort of a huge organization which we didn't know how to navigate into. We didn't know who to approach. So we just really felt, you know, we wouldn't be able to access this you know, close partnership that we now share. So we felt that it was inaccessible. It was huge. There was no access point. Nobody to sort of approach, and sort of too many strands to it. So we didn't understand it, and so yeah, we were not able to sort of engage with them. Yeah.
Thank you, Molin. I think, and I always remember, and I said this to you the other day, the first time I ever met Molin was probably a year before our we funded the project and the partnership. And again, I was I think I was fairly new in post and trying to make some network connections. And Molin and I had a Teams meeting, and she scared the life out of me. I'm not going to lie, because quite rightly, she is a fierce woman protecting her community. No, you are. You know you are. Protecting her community. And I think I remember what you said to me. You said, we've tried to engage with maternity before. We've tried. And actually, you just don't show up. There was no consistency. And that really stuck with me. It was a real lesson for me in learning that actually, if we show up, we have to continue to show up. So that's one of the things that has stayed in my head. Okay. So the other thing that we did early days was a equality and health inequality impact assessment. And again, before this work, I really didn't know what one of those was. But luckily, in the ICB, and the ICB is the Integrated Care Board, and then you've got an ICP, which is an Integrated Care Partnership, and then you've got an ICS, which is an Integrated Care Strategy, because who knew? Anyway, they're all the same thing, really, and in just different terminologies sometimes. But there's a lot of skill sets. They are skill sets that I don't have because I'm a midwife. But actually, there was an interim intern working within our ICB, and she was working on the EDI agenda. So we co-opted her in, and she was amazing, and she completed the impact assessment for us, and it was very, very interesting. But for top tips, use your ICB. We've got a PMO, and she has written the business case and done loads of the project scoping, well, all of the project scoping, and has been absolutely integral to this. But we also have an ICP Equalities Programme Manager, we have an ICS Analyst, and we have an ICS Health Inequalities Intern. And that all sounds a bit scary, and I had to go and find out who they are, but they have been valuable. So I think if you're thinking about how to do this, we need to collaborate. I won't go through this. There was a project proposal, mostly written by our PMO because she's phenomenal. And we looked at some expected outcomes. If we go into this project with our third sector, with our VCSE volunteers, what are we aiming for? Knowing very well that that might change, but we had to have an idea. So we were very much focused on social prescribing, signposting to other support groups, advice, reducing isolation, improving perinatal mental health, feeding your baby, understanding the maternity pathway. It was enormous, but we left it fairly loose. So my top tips, if we're going into working alongside partnerships, we needed a business case, and then we needed a project proposal. We needed a tender process, and again, I needed to understand that, but that's why I needed a contracts expert, and there are those sitting in the ICB. And again, not me. We needed a finance director. And then we needed the VCFSE assembly, because there is one usually sitting in every ICB. And if you're not familiar with them, go find them, because they're an amazing source of wisdom, actually. We needed public health because they pulled the data. And then we have alliances, and alliances sit within your footprint. We have 3 alliances, one in Ipswich, one in Colchester, and one in West Suffolk. And they lead on the place-based stuff. So they're very, very local. But if we're going to do something right across our ICB, then the alliance leads absolutely need to be involved. And that includes the county councils as well, because anything we do in maternity impacts the rest of the world, doesn't it? Including primary care and health visiting and county councils. You need to evaluate. And I have to say that's been a real challenge, but it's absolutely essential. You'll need to keep an eye on sustainability. It will be hard, is what I'm going to say, but so worth it. Let's talk a bit about co-production. And I know we all talk about co-production. For me, this is absolutely a collaborative. And I think there's a lot of talk about MNVPs and how overwhelmingly the ask of an MNVP is enormous, quite rightly so. I think the role has changed even in the last few years, 3 years or so. So it doesn't sit solely with the MNVP for me. We are absolutely a collaborative. We started off creating what I called an equity forum, which has now turned into something called the I Matter Forum. And that was the name that the forum itself gave it. We have in that I Matter Forum all of the community leaders. Molin sits on it, and all of the rest of the community leaders, as well as the heads of midwifery and Home Start and Health Watch and the ambulance service sitting there, and Suffolk Police, Calm and Health Visiting. We also have an LMNS co-production lead who sits alongside us, and of course the MNVP. But I see co-production as everybody's business and not sitting with one particular sector. We've invited all of the birth workers, so that means the NCT, the local doulas, aquanatal classes. So it's very, very diverse, because that's the only way we're going to get any rich feedback, I think. So I'm going to hand over to Molin, and I'm going to say, can you tell us a bit about who Phoebe supports, Molin?
Yeah, thank you, Terry. Phoebe, we support women from Africa, parts of Asia, Eastern European women, so all women who come from abroad, who are migrant, and usually they are vulnerable and do not have the support that usually a woman who is pregnant and expecting her baby, sometimes the first one, usually has. And we support women who we've got, I think half of our referrals are coming from midwives for domestic abuse support. So we support women who are migrant, alone, who have insecure immigration status. So that means they can't access the normal and everyday women's refuge because of their visa status. And so those are the women that we support at Phoebe. We also support the children. We have children's activities that we hold at the center.
Wonderful. Thank you. And we are going to move on to talk about the grandmothers. Can you explain a bit about the grandmothers and why the grandmothers?
Okay, as a result of our involvement, as a result of starting the maternity work, which we started during COVID, and as a result of the equity fund that Terry has mentioned, we obviously, as Africans, the first people we turn to when we are pregnant are our mothers, our grandmothers, because obviously they carry on the tradition. Some of them are lay midwives within the community, and the ones that we work with at Phoebe at our center, some of them are retired qualified midwives and nurses, and so these are the first people we felt naturally inclined to sort of involve in this project, and there have been a wealth of information, of support, practical help to the mothers. We sort of absolutely enjoy working with them because they understand and know the process of birth and how women need to be supported. They are key in our communities because traditionally they carry forward practices that women sort of have to sort of take on when they're pregnant. And so this has been very interesting for this project because obviously the women come from different parts of Africa, and they have different traditions that they hold within their communities. And it's been interesting to sort of marry the two, the obviously the statutory requirements and expectations of midwifery here in the UK, and then actually dispelling any myths that women might hold, as a result of the teaching and the hand holding that we've been, taking with, the NHS midwifery maternity processes with Terry. Yeah. Thank you.
Thank you, Molin. And we're going to talk a bit later about the impact of the grandmothers. So as Molin was saying, they have created kind of formally created a grandmothers group. So within that grandmothers group, we have had 12 months of focused groups, and I suppose you could call it training. And that involved me going every Monday to meet the grandmothers. And when I said to you earlier that I found Molin quite fierce in that first meeting, to be faced with actually the whole group of your grandmothers, Molin, on that first day, they are a fierce bunch of women. I think the average age group is around 70-ish. And they are very no nonsense. They are very experienced, no nonsense women. So within those meetings, we are exploring the cultural differences between us, but we are embedding the UK expectations and understanding from maternity's point of view why local inequalities exist. And so the grandmothers were able to give us really great insight, actually. Of course, it was strengthening our relationships and bringing us all together at the same time. So from my point of view, I created a Padlet and a training tracker. So we went every month and we focused on a different topic, and I've given them loads and loads of information on a Padlet form. There you can see some of the grandmothers on one of the Mondays. You can see that the June topic was childhood immunisation, and I frequently took a guest with me. So sometimes it was a local GP practice. May topic was FGM and male circumcision, and I took the Ipswich maternity team with me to talk around that, and we'll come back to that subject actually because that's featured really heavily in some of our conversations. April we looked at infant feeding, and the infant feeding team came with me. March we looked at relaxation and the benefits of that in the perinatal period, and February we did a whole focus on induction of labour, and the co-production lead came with me. That's just a snapshot. We've covered many more topics than this. So it's been rich and diverse, the conversations. And I think what I've gained, and I always say that I've learned much more than they ever will, and so it's been an exchange of learning. They tell me stuff that I've absolutely had no idea of, and I will then take that and feed that information back to the operational staff, and of course then I can tell them a bit about maternity in the UK. And what I've been really impressed at is their open-mindedness to it, and their changes in practices, because sometimes where they come from is very, very different. So I'm going to, if I can, just stop sharing, and I'm going to show you a very short video of the grandmothers because they wanted you to hear from them. personally. So I'm just going to reshare a different screen if that's okay. And I'll just pop the grandmothers up so that they can talk to you. There should be sound with this. If there's not, can someone please shout?
I'm Cecilia Omole. I work for Phoebe Grandmothers Group.
Is it me? I can't see the video on here. Sorry.
Helping in Phoebe. If definitely we know when we just arrive and there's nowhere to go to and you are pregnant, there's bound to be fear when you don't have anybody to. And that is why this organization is so important. We work in Phoebe to support the young mothers because they seem to have developed confidence in us. Like I was faced with an experience of one of our young expectant mother who has some problem, has earlier spoken with the midwife, but didn't really tell her all that has come with her. But when she called me, she was able to tell me everything that happened. I have to say then she needs to go to the hospital, and I assisted her to the hospital. So we are just encouraging them to be more open and be open with the midwife, tell them whatever is happening so that they can help them, so that they have a safe delivery. The baby will be fine, the mother will be fine. That's what we are trying to incorporate into the mother. You know, it's quite different. The way we view talking to, or the way we perceive things. Pregnancy, giving birth, is a little bit different, in the sense that the custom, the custom and the taboos, you know, our grandmother, like, okay, let me give you an example. If you are pregnant, you don't go out in the afternoon. Yes, because your baby might be transformed. So that's it, you know, it gives fear. So you don't go out like 1 o'clock when you are pregnant. And if you want to go out in the afternoon, you have to tie a pin to your clothes so that if the evil spirit that flies about, you know, might not attack your baby. But here in Britain, it's quite different. You are free to go, no fear of any kind. You can even show the picture of your baby right in the womb, and you can even tell people you are going to give birth the next day, but not like that in Africa. Not like that in Africa. You hide everything because of the social background. At times they still try to keep something secret, but we are trying to go out of that, and we are winning. We are influential in the community in the sense that we have gone through the stage they are now in. We've been grandmothers for years, and the experience we gather, they know we know what we are doing, and they don't have any fear as to that. So we are very, very influential in there, and that has given them a kind of relaxation, a kind of confidence in taking care of themselves, you know, at home. Tell them about what to expect in pregnancy. We work together with the NHS group. They tell us their syllabus, and we try to discuss following the syllabus, tell them, and talking about the cultural background and what it is being practiced now, how they need to change so that things can go well. You are making a lot of, you are giving us, you know, things we have even forgotten. You remind us of it, you through your training. So that is a kind of support. The training, you know, is the community nurses, you know, midwives, you know, come here to train us more, to support the young one, the mothers more, the pregnant mothers more as well. It's great. And I cherish you, and I say thank you.
Okay, I'm just going to return to our slideshow if that's all right, and we'll finish up with the presentation. Okay. I'm just going to click on that and get back. Okay, so just to give you a bit of an idea now around the support. So again, this is not just Phoebe, but these are the whole of the 6 organisations that we've funded in Suffolk and North East Essex. You can see that, and this was only from June to March, June 22 to March 23. They supported nearly 1,000 people, and that was 492 families. Who contacted them for support. The types of support that our VCSE partners are providing is really broad. So it's translation and advocacy services, it's signposting to other organisations. There's a lot of food banks and household funds and wellbeing, and explaining the maternity pathway and leading to a much more clarity and less misconception, really. And we've got some groups attending there that you can see there. And then again, here you can see signposting to mental health. Any complaints that they feel that they haven't got a voice, then our VCSE partners are steering them towards us, Healthy Start and even careers. The other thing that we do is provide some learning and sharing learning sessions. So 3 times a year, we've brought the VCSE organisations that we fund together, our maternity partners, and they all come in together. It's always a fantastic day. There's always some food involved. We all get together and they present what they're doing in their own organisation and just do some networking across our LMNS, and that's been amazing. So I'm going to go back to Molly now, and I'd like to ask, what's it like working with maternity in the NHS generally now?
Just to say, I wasn't as fierce as you described,
Yeah.
Terry. It's just you know that you know, you're sort of used of people coming and taking information from you, and really nothing happens afterwards. So you know, really, we've reached at that point where we just sort of you know, we had nothing to lose basically. So we just generally told people to either go away or really put their money where their mouth was, and so, and we did tell that to Terry, and she did exactly that. She just said, Mollen, this is new to me, and I'm going to be standing with you. This is what I need, and this is the plan. And she said, well, we have to prove our case and really have to sort of crack on and work. And we said, well, that's what we've been doing all along. And so we needed someone like Terry because we were able to communicate with her as the contact. So she was navigating the sort of the maze, a huge sort of you know, we feel the NHS is just really complex, and so we over time, as she said, it's been over a year that we've created this strong relationship, but it was really about meeting together, talking over cups of tea, food, and listening to one another. So it was not only Terry, but all her colleagues who we felt were inaccessible to us, and so that bridge was slowly sort of you know, that gap was bridged, and we were able to sort of you know, create relationships with you know, the NHS colleagues. So we own our own building, so we've just recently moved into our own building, and so that center is really now home to the NHS community midwives as well. So Terry has managed to get them into our center, and they hold surgeries there now. And so our women know to come for support and help, and they know the importance of accessing midwifery early. And so it's all sort of gelling in, you know, quite nicely, but it's been a lot of work that we feel needed to be put in. Basically, it wasn't an overnight sort of piece of work, but it took many, many months. And also we realized that Terry has and her colleagues are pushing for funding to support our work. So there's a lot of expectation that voluntary sector just need to volunteer, basically no money, just come and volunteer your work. But obviously that's not possible. So we realize and we know that there's a clear commitment to sort of sourcing funding, and that understanding that actually people need, you know, to be valued, and we need, you know, to be well resourced. And so the the notion that Black women are sort of 5 times more, likely to die at childbirth. Yes, we know, and yes, we've heard about this. We really wanted Terry to come to us and to say, Mollen, let's find a solution for the women of Suffolk. What are we going to do, in order to avoid this? And so I think, Terry, that when we started talking, the first focus groups, women were telling you that they were giving birth in taxis. Several women said that actually I gave birth in a taxi. I was told to go away. I didn't know where to turn to. I didn't know, what to do. And really sort of graphic experiences, during childbirth. And so at the moment, we really are working towards sort of supporting both the mothers and the midwifery teams in order for us to really sort of have positive outcomes for our Black and minoritized women and their babies.
And
Yeah,
if you had
you.
one top tip that you gave to everybody about recommending nurturing the relationship between the VCSE and maternity, what would be your top tip?
Okay, first of all, you need to bring the money. You need to tell us you've got money to give.
Yes.
Because
Yes.
honestly, every single day we have surveys put in our faces. Everyone wants to find out the same story. Yeah. What are your experiences? What can be done? Yeah, we need to, so we really need people who are committed, to offer a holistic partnership. Yeah, we need the expertise, we need the training so that people can be confident, in delivering this work in the community. We learned a lot about water birth, for example. That's not common in our cultures, but it's really good. So, and then obviously we need the support resources to back up this work, really. So those are the tips, really. So the two come together, I think. Yeah.
Thank you, Mollen. Okay. So outcomes, we and we're still under evaluation, but we know that people are experiencing improved emotional well-being, less isolation. We are really myth busting, and especially work around the NHS and the payment pathway. So we've done some work on that. Just education generally, and what are the cultural norms?
Yeah.
The next steps and the challenges, working with staff is a real, and I'm talking about midwifery operational staff, to communicate this message. So I'm really well embedded in these organisations, but actually I think I've told the operational staff and then I have to tell them again a month later and again, because the turnover is enormous. And, I work across a big patch. So it is a full-time job to communicate what I'm learning so that everybody understands it. We're extending the offer because there are some areas that are very rural, and Molly and her team are extending it to the West Suffolk area. And we also want them to deliver antenatal education as well. And that's a real move forward for us. But again, funded. And then capacity for this work. Who does this? Because it truly is a full-time job. And then having an eye on the funding and having an eye on sustainability is something I mentioned earlier. And myself and Helen, who is our PMO, have always had an eye on funding. As a working in transformation, we have non-recurrent funding every year, and we never quite know what we're going to get. We had a 15% reduction for our LMNS this year. And that then impacts on the sustainability of our VCSE partners. And we don't want to do what Mollen experienced the first time round, which is swoop in, promise the world, and then never show up again. So for us, this is something that is sustainable. And we are, Helen has just written a business case, and we are going into the ICB to ask for £500,000 to continue to fund the work that we're already doing, because it's that important. Thank you so much. Are there any questions? I'll stop sharing.
Thank you so much, Terry, Mollen, and the grandmothers for sharing the amazing work that's taking place. If anyone has any questions, please pop them in the chat. There's a question around some of the practicalities, Terry. Did you create individual KPIs for each organisation to meet, and was the 50k a one-off payment, or have you created any contracts with the organisations?
Okay, so KPIs are something we love it as health professionals, and KPIs are not something that I've discovered that some of the third sector want to work alongside. So we did have a project plan, and I showed a bit of it earlier about, reducing health inequalities. But actually what I've discovered is we need to go in, and these organisations are the expert, not me. If I go in with a whole load of KPIs and with my NHS head on, it's just not going to work. So I'm going to say no. I let them lead. We let them lead, quite rightly, because they're the experts. Why would I pretend to be an expert in Molly's community? She knows what they need. And I think if you're going to work with the third sector, the biggest learning I've taken is that I know nothing and they know everything. So stop with the KPIs, although that will undo you when you come to the director of finance for the ICB, who is now telling me that I have to prove that it's made a difference. Because of course the soft outcomes, the qualitative stuff, the way people feel about maternity don't count. And that's tricky, because what he'd like to know is how much money I've saved by reducing stillbirths. And in a year and a half, I can't evidence that. But that's actually what he'd like to know. But we know we've made a difference, but it's not something I can prove to a DOF. What was the other part of the question? Sorry.
I think that covered it. Sorry, I've lost it now. I scrolled. Yeah, I think you answered the point also towards the end of your presentation around it being a one-off payment. I think you mentioned that you were putting a business case together for the future. Thank you for that response. Marlon, there was a question around how the grandmothers came together within your organisation.
Yes, we are a grassroots organization and we offer sort of ongoing support. We've been around 15 years now. And so we offer support to older women, befriending support. So they're part of our organization already. And so that's one of the sort of key about working with voluntary sector and people like us, is that we are already embedded in the community. So we wouldn't be able to just sort of suddenly ask people to just turn up and be part of a maternity project from nowhere. So they're already trusted and they're part. We support them financially. Sometimes we support them with activities, well-being activities. We have a walking group. We have Zumba. So they're sewing and knitting. So they are already part of our fabric, and they are the grandmothers of the organization. And so this is just part of the work that they're doing. Yeah.
Amazing, thank you. Annette, do you have a question?
It's on your mute.
Hi, thank you. Oh, thanks. That was absolutely excellent and tremendous work being done, obviously. My question's for Terry, because you mentioned a couple of times about being terrified. And I have an excellent colleague. She's very committed to this work. She's really has great vision for the work that we're going to do together. And she said in one of our first meetings that she'd rather do nothing than get it wrong. So I'm detecting a lot of fear around working with particularly the Black community, but also other diverse ethnicities. There's fear, there's a sense of, if we keep having meetings and keep having groups and keep putting plans in place, we're doing some work, where actually that's not the work. But you seem to be working with fluidity and efficacy. So I want to know what it took for you to overcome your feelings of terror and, whatever there was there for you, so that we can actually help other people doing this work to really connect with, we're all people, and just get in touch with their humanity so that the work can start. Because I love all this and I think it sounds lovely, but actually it gets my blood pressure up that there's not actual work being done unless it's grassroots. And I think we've got resources, we've got absolutely tremendous talent in the NHS, but the work is paperwork. So my question is, what was the mental shift, or what was the emotional shift that took place, or however you want to deliver it?
Oh, thanks, Annette. That's a great question. There is a lot of fear. I was fearful, and I still am. I'm not going to lie. When I met with Molly, and then I met with one of our other community leaders called Rachel, who owns African families in the UK as well. And I went in with my NHS brain and I said, can we survey your women? Can we ask them how we can improve in maternity? I was very much clipboard focused. And Rachel looked at me and she said, no. You have got all of the answers you need. You have an Embrace report that tells you our women are dying. Stop talking about it and start doing something. And which case and then it comes back to capacity, because I had to email my boss and say, well, if you need me, I'm going to be out with Molyn and Rachel putting in the time. But I am across an entire LMNS, across the entire transformation program. This is not my full-time job. But Molyn was emailing me going, show up every single month for the grandmothers, because that's the kind of commitment that they wanted. There was a lot of fear from me being a white middle-class midwife showing up into a different culture. And we talk about cultural differences and it works both ways. I had a lot of fear of putting my foot into it, saying the wrong thing, being inappropriate. And when interestingly, we did a midwife survey as well, and I asked them if they were addressing diversity in their conversations, knowing that women from diverse cultures suffer worse clinical outcomes. Did they address that? Did they say, we're going to look after you because you have black or brown skin? And do you know what they said to me? No, we don't talk about it very much. Now, this was a very small snapshot. It's not that the midwives don't want to talk about it, but they are terrified of saying the wrong thing. So we've created a culture of what I call cultural curiosity, which means that I'm curious, but I'm not an expert. And there's a lot of cultural awareness training, and I've got a real problem with the term cultural awareness training, because people think that they can go on a half a day, tick a box or do an e-learning and they're experts, and there's no way we can be an expert. But I am culturally curious, and Molyn's allowed me to be that, and I feel safe to do that.
Yeah. Yeah, I think, yeah, well, I'm a social worker by profession as well. So that really helped, Terry. And also we sort of were able to say to her, we spoke and we were able to say, no, this is what we need. It's probably not a good idea for you to ask us again about what our needs are. You know our needs. So we were able to have open conversations, and I feel that was the key, and that's why we can laugh about a lot of things. So we're allowed to laugh about not very funny things. We can laugh about them. So and that way we have a relationship which we feel safe in making mistakes. I think that's really, really important. And I think many people feel, the assumption is I might say something wrong, I might be complained about. So I feel, yeah, that is a big barrier. Thank you, Annette, for asking that. And that was the key. And when she, Terry, when you met the grandmothers, you're like, okay, this is what they all like. So I better just be comfortable here.
Exactly. You have to get used to it. Just
and
get on.
Yeah. So I feel just, a lot of icebreakers and just really being sort of open to each other and sharing as human beings. I think has been key to this relationship. Yes. And also the relationships that you have with the other groups as well. So we have Eastern European women being supported, the young people, all of us. So when we've managed to gel as a group, as an entity, and that has been key to working together moving forward, and all those sort of useful, helpful meetings that we've had, which we feel have benefited us. So we've been in lots of local authority meetings and NHS meetings. I feel sometimes a lot of time is spent just meeting without any outcomes. So for this project for us, every meeting has been helpful to us. Yeah.
That's fantastic. Thank you so much for both of your answers. And I feel like your testimony could help a lot of other colleagues and to shift their mentality. And I'd like to speak to both of you if possible. So could we exchange details, please? Thank you.
Thanks so much for a great question, Annette. And absolutely, it's something I sort of hear when I'm going out and speaking to people. And hopefully, again, just going back to that point of just sharing where we're at. It doesn't have to be an end product yet. We don't have to have all sort of the answers about how to do it the absolute perfect way, and just having these spaces to sort of talk through. Anyone who's keeping an eye on the time might notice that we've run out of time for the breakout room. So what I'm going to do instead, and hopefully this keeps you all on the call for a few 10 more minutes, is to just use this space to have those sort of discussions that I was going to suggest we have in the breakout rooms. So it was really just a time for people to talk about whatever they wanted to, share sort of reflections on the presentations. If speakers are still on the call, answer any sort of remaining questions. But also, if anyone sort of felt, oh, I've taken something away that I'm going to take back to my local area and think about, or if there's anything similar or slightly different that you're working on that you'd be keen to share, any challenges you'd be keen to hear sort of other people's input on. So please use this next, where are we at, 10 minutes to do so. Maduri, do you want to start?
Yeah. Hi, all. I thank you all for your input. It's been amazing. It's been a wonderful session. I shared earlier, I work with Celeste. I work in SANS as a bereavement support services officer, and my focus is on loss within the South Asian community. And my colleague Patrice has the same focus for the Black community. So we deal with pregnancy outcomes and loss and all of the loneliness, isolation that comes with both communities, and the taboos. But we also look at, we speak often about discrimination and health, but we do not speak about all of the other things that are within that so badly need to be spoken about, but they're sort of taboo words within the NHS and within all these services. So if anyone wants to reach out, I'm going to put our links in the chat, and it's got our email addresses. We'd be really happy to hear from you. Thank you.
Thank you so much for sharing that. Anyone else have any thoughts, questions, reflections, any bits of work you're keen to share? Come on, oh, Victoria.
Yeah, so one of the things that I picked up from the conversation, and it's really amazing work, is perhaps some of the difficulties that you guys might have had in terms of the evaluation and making the case. And one of the things that we're looking at the moment in the evaluation of the equity and equality guidance, is there any further support that we as a national team could do once that would be useful for a number of LMNS? And whether something around a little guide to evaluations, how you might think about, when you're doing these projects with the VCSE, when they are kind of addressing the social determinants of health, and you're not going to see necessarily an outcome in terms of stillbirth rates or maternal deaths. How could you be helped to make that business case? I'm just interested for views on that. Is something we might test in the field work.
Are any of the current hands that are up in response to Victoria's specific point? Terry, I'll go to you first and then I'll come back to you, Louise.
Yes, yes, and yes. I wish I'd given it more thought at the start, if I'm really honest. And Helen, who is our project management officer, did create a kind of an evaluation form that didn't sit so well with a lot of the VCSE partners. So we did absolutely, well, they adjusted it for us. And I think at the end, when you get to the end of a project, you don't realise how important the evaluation is. But and again, I'm not an analyst, I'm a midwife, and I would really appreciate some support nationally with how to interpret data, and also some support nationally about the soft outcomes, the qualitative outcomes that are just as important as the hardcore stats that we might produce from here. So that, Victoria, would be amazing. Thank you.
Yeah. Great, thank you. Louise?
It's been really great to hear all of the work that's going on, and I suppose listening to and reading the chat here, I wonder if there is a possibility of having somewhere that captures all of these different things. I'm thinking about, for example, the digital tackling digital poverty, because lots of people here are saying, oh, I'll get in touch with you to find out more, but if you don't know about it, you don't know about it. So it would be really useful, I think, to be able to capture these excellent projects that are happening in a centralised place, so that if you are struggling with, say, digital poverty, then here you go, this is something that's working, or something that they're trying, and it would be also useful to save time if there was a way of having a bit of a, okay, so this is where we started at, and what we wish we were aware of, or what, you know, things to think about before you start diving in, because that saves time for one. Okay, you can't exactly replicate in every area, because there'll always need to be adjustments, but there must be some starter points to prompt people. So instead of every area trying something, making similar mistakes or challenges, it taking longer, just to have something that, okay, if you're looking to tackle this, these are some things to think about, this is how we're doing it, and these are, you know, whether that's evaluation, whether it's who to look for, or how to engage with local services. I'm just wondering if there's, instead of relying on people either watching these recordings or coming to these meetings, if there's a way of capturing the amazing work that's going on somewhere, where you can just go and see.
Thank you, Louise, for what I think is an excellent point, because it allows me to plug what we're doing as part of the Maternity Consortium. So that's absolutely what we're trying to do. I often will go to sort of meetings, events, present on some of the stuff we're doing, and perhaps hear about what other people are struggling with and signpost them to something, and I hear it's very similar, like, oh, I wish I knew about this before. So that is what we're trying to do as part of the Maternity Consortium project. So once this event is over, my next task is then to be doing a call out across LMNSs, Maternity and Neonatal Voices Partnerships, VCSEs and other partners who already have existing free resources out there, and then sort of thinking about some of the challenges that have come up in this event, in previous conversations I've had with people, and some examples of good practice that people have requested, develop some new resources. And then the idea is to put that all in one place, as you say, that we'll have like different folders for specific things that people can access. So that is absolutely something we are trying to do, and we're working with Victoria and the team at NHS England on that. And anyone who has anything they want to sort of submit to be part of that hub, or ideas for things that might be helpful, do get in touch with me. Happy to have a conversation about it. I can't promise the world. We will do our best to sort of gather what's out there, and with the sort of funding and resources we have, develop some new things to try and address some of the things that have been raised to us. But really, thank you, Louise, for sharing that. It's a really important point. Who is next? Jodie?
Thank you. Hi everyone, my name is Jodie Dedman. I'm the Programme Director for the LMNS in South Yorkshire. First of all, and I'm sorry to take up time, but I do just want to say thank you for putting this on. You see a 2.5 hour meeting drop in your diary and everyone's size, and I can honestly say this has been the most productive 2.5 hours of my week, so thank you very much. Secondly, just back to the conversation and points raised around KPIs and how we evaluate some of this stuff. So Victoria, I think there's possibly some national join up that we can do here. So in South Yorkshire, we've just secured some funding through a joint proposal with our Children's and Young People's Alliance, and there were some quite specific things that you could bid for the funding for. So some people did things around kind of oral health and reducing ED attendances, emergency department attendances for young people, but it were broader than that. And so our bid is around a holistic kind of early intervention, prevention, whole family model, supporting access to kind of healthcare, but equally some of those things that Terry talked about around kind of employment, housing, we're working with individual communities. But so we're just at the procurement stage at the moment. We've gone out to procurement for that to be led by the voluntary sector, and it's around 400,000 a year over a 2-year period. But attached to that, there will be kind of some evaluation or a way to evaluate it, and it might be some of the outcomes stuff. But there'll be lots around kind of experience and various things. So I suppose one of my questions is, Terry, can I link in with you, because you've clearly done some of that work and it'd be great to learn from what yourself and Molly have done. But secondly, Victoria, I think some of that joined up work across that programme might help with some of the broader work we're doing around equity and inequalities. There's a pocket of pilots that are kind of in this area, so there'll be some learning coming from that.
That's absolutely brilliant. Thank you, Josie, and sounds actually really interesting pilot in and of itself, but yeah, sounds like we could learn around the evaluation from side for that. So thank you for that offer. Could you just drop your email in the chat, please? Thank you.
Thanks, Jodie and Victoria. And I'll take the final comment from Louise and then I'll wrap up.
Hi, I just realised I've got my wrong camera on, but anyway, yeah, I was just picking up on the evaluation point, and one of the things that occurs to me that might come out of this project, which sounds fantastic, is earlier bookings, and that would be something measurable that people could come, could show for things. But I think actually some powerful stories might help to enhance the presentation of outcomes as well, and get some of the soft stuff over. Just a thought.
Thanks so much, Louise. Molyn, final thoughts, and then
I just wondered, another measurable sort of opportunity would be for evaluation would be the relationships between the NHS and voluntary sector, because for us that's actually key. So I think that relationship, the fact that we have midwives coming into our center now, the fact that we have health visitors and the mental health team, the maternal mental health team, perinatal, are also coming in. So perhaps that could be sort of a measurable sort of opportunity. So a lot of qualitative sort of opportunities for sort of measuring the project, I think, would be key for this project. So yeah, I think, like Terry said, we would really need those experts to come in and help us, but I feel those for us are the key, that nothing can happen if we don't speak. So yeah, thank you.
Amazing. Thank you so much. Okay, well, thank you so much to Victoria, Fiona, Mandy, Steph, Grace, Terry, Molyn, and the grandmothers for all of the work that's gone into the presentations and delivered today. Thank you to all of you for attending. Really appreciate your time and your sharing your expertise and insights and questions in the chat. I will ask if you could please complete a very short evaluation form. It helps us to understand what's helpful for you guys, and if there's other things we could be doing to sort of respond to any of the challenges you're facing. So I'll put that in the chat. I'm also going to email it to you, and I will send over the recording, the slides. I will try and pull together any links that have been shared in the chat. I'll try and pull that all together just in case people can't access the chat after the meeting ends. But I think I've covered it all. Thank you all for your time. Hope you have a great rest of the week and a good weekend when it comes. Take care.
Thank you. Bye.
Thank you.